I entitled this Return of Corky the Killer, and you'll see who Corky the Killer is in just a few moments. Does anyone know who this is? And it's not Dr. Canella, although Dr. Canella is about as smart as this guy. This is Sir William Osler, and I think most people know that the famous quote from him was, "He who knows syphilis knows medicine." And it's kind of true because of the different manifestations that one can see with this disease. Just to give you a brief timeline of syphilis, back in 1822, it was Antoine Labial who first noticed psychiatric symptoms. Of course, they didn't know it was neurosyphilis, but did on autopsy notice chronic inflammation of meninges in some of these individuals, and later on was recognized as probably some of the first recognition of neurosyphilis. One of the things they tried to treat some of these patients with these skin infections and other things was potassium iodide, and you can imagine that that worked unsuccessfully. Going into the 19th century, we saw venereal disease epidemics, including syphilis, spreading across Europe and getting into North America, and there's been this back and forth of did the old world bring it to the new world, or did Columbus bring it back during his time here? And when they've looked at genetic analysis, it looks like it probably was a mutation from yaws or endemic syphilis that was around in parts of Europe many, many decades ago. But I think it's still, people are still not sure. And at this point, it doesn't really matter. We know that people who had syphilis, because there wasn't any really good treatment at that time, they had a 5 to 20% lifetime risk of syphilis. In the population, about 6% would go on to develop neurosyphilis and have some of the complications a little bit you heard in the song. It was treated effectively, or obviously not effectively, in public asylums and private clinics, because we didn't know what to do with those individuals. In 1905, there were two Germans, Schaudlin and Hoffman, who actually discovered the causative agent, which they named at that time Spirochaeta pallida. In 1906 to 7 is when the Wassermann test became available, got him a Nobel Prize. It was really not a great test. It was a complement fixation test, and it wasn't very specific, unfortunately. It would pick up other inflammatory diseases, autoimmune diseases, etc. The first big step, as most of you know, was compound 606 that Paul Ehrlich had, that was also brand named Salver, which is interesting because it was an arsenic compound, and the real name for it was arsphenamine. It blocked the development of primary and secondary syphilis, although it had a relatively narrow therapeutic index, as you can imagine, with it being arsenic. And in 1943, John Mahoney, who was U.S. Public Health Service physician and head of the Venereal Disease Research Center that was looking into testing for this disease, and came up with the one test that was named after it, the VDRL, showed that penicillin was extremely effective, even at low doses, in treating primary syphilis. This is a persistent recurrent problem because it's still an incident and prevalent disease, despite us having adequate and cheap treatment for it, and it's associated with an increased likelihood of HIV transmission, congenital infection, and along with that, fetal loss. So where are we at this point? What's the state of the states with STIs, or even the CDC still calls it STDs? This slide is just looking at, or this graphic is just looking at bacterial causes of a sexually transmitted infection. So it's not the most common, but when you look at some of the problems that we see associated, it remains problematic. Not as common as chlamydia or gonorrhea, but it's amazing that it's still around and it's starting to come back and get worse again. So you're looking at this graphic, and what you see, see if I can find this. Here we go. So what's going on here is 1941. Well, you know that penicillin started becoming available getting into 1946, but we started seeing more control mechanisms, contact tracing, etc. And syphilis. So what you're looking at is this hump here. But after penicillin was introduced, we saw a relatively fairly well controlled incidence of this disease, although that the amount of money put into public health at that time was not as robust as everyone would have liked. And then there's a little bit of a bump in the late 80s to early 90s. And part of that was because of drug use and people sharing sex for drugs or sex for money for drugs. So then what happened? It became endemic in many parts of the United States, and we've always seen higher rates of syphilis in the Southeast, the Southwest, and going up the West Coast area. We don't actually detect a lot of syphilis in Alaska, but if I were to show you chlamydia and gonorrhea, it's a real hot spot for both of those illnesses. So we've always kind of seen this, and trying to get testing in populations to look for syphilis has been a function the CDC and state and county health departments have been pushing for a long time. When we look at this, you see a little difference than if you were looking at gonorrhea and chlamydia. Usually you see the male to female rate is closer approximated and would be close to a 1-to-1 ratio, whereas this is really skewed towards male patients. And as you see, it's even skewed towards some older male patients, which is a little different than what we would normally see with gonorrhea and chlamydia. So when you look at the difference between it, we do see that MSW, men having sex with women, kind of closely follows along with the amount of syphilis in women. And this is primary and secondary that's reported. But our MSM population is unfortunately bearing more of a brunt of this illness. Just the same kind of thing, and then you just look at the male to female ratio, and it's obviously far away from 1-to-1. So this has been a real focus for health departments and for many people in public health, in the VA system, etc., is trying to identify people who are sexually active, especially people getting PrEP, and make sure that we can try and screen them for not only gonorrhea, chlamydia, but also for syphilis, because that's where we're seeing a lot of this disease we just noted. The unfortunate part about T. pallidum is that it does not grow well in artificial media. It really needs select media. Animal models work fairly well. Sheila Lukart, Dr. Lukart's up in Seattle, I think is retired now, but had for decades done a lot of syphilis research in the lab using rabbits, etc. It is a very tightly correlated spirochete. It's really long, but it's really thin, and you can't see it even in oil immersion in a regular light microscope, as everybody knows. So you have to use a dark field condenser where you're bouncing light off the sides and illuminating these spirochetes from the side. Unfortunately, nobody teaches how to do dark field microscopy anymore. So it's kind of a lost art, but it was a rapid test for a lot of people who had a lesion syphilis. You could do a dark field, see if you see spirochetes, and you kind of made a diagnosis, unless it was an oral lesion. Sometimes you can see some of the oral spirochetes that would confuse people. The other important thing to remember is that T. pallidum, like other spirochetal bacterial infections, has a fairly long replication time of 33 to 36 hours, and that's when we talk about treatment for that. That's why you want penicillin to hang around for a long time if you're giving it as a single injection. Either that, or you have to give it as daily injections with probenecid to keep it in the body for hopefully hours. But since it grows really long compared with gonorrhea that takes 30 minutes to replicate, you really need to treat this longer than you might with gonorrhea, etc. We know that it enters the body through skin and mucous membranes, through abrasions, usually during sexual contact. It can also go transplacentally, and it gets disseminated, it goes everywhere, it gets into lymphatics, goes everywhere, and even into the CNS, and it can do that at any stage of syphilis. So it's not, in secondary or later syphilis, it can even do that with primary syphilis. So here's where the title came from. This was an interesting book that came out in 1945 by Harry Wilmer. Dr. Wilmer was a pathologist, and he was trying to educate individuals about how syphilis worked. And again, this is just as penicillin is starting to come out. I saw a copy of this book one time when we were doing training in Atlanta. I offered to buy it from the lady, and she told me $500 would probably let her take it from her hands to mine. I thought that was a bit much. You can find a few copies online. So I did the next best thing. I just took my phone and took of all the ones, and it is really actually interesting. And you see there's an introduction here from Tom Perrin, who was running U.S. Public Health Service and was a Surgeon General at the time, about how nice of a book that it was. I think it's important because many people haven't seen syphilis for a while, but now it's been coming back for the past literally 10 years. People are starting to see this and may not know what it is. So just to remind you that the primary lesion of syphilitic chancre develops at the site of inoculation, which might be visible or might not be visible. If the site of inoculation was inside the rectal cavity or on the cervix, it's not going to be obviously something that people will see. So that's one of the issues with people not seeing something, is it might be in an area where they wouldn't normally see. It could be in the back of a mouth. We've seen pictures of chancres on uvulas, etc., and if it doesn't hurt, they may not notice it. So again, usually these are painless, indurated with a clean base, as opposed to chancroid, which is painful and has a dirty base. These are really infectious. Lesion syphilis is really infectious, and that's why public health gets really anxious about when you call in somebody has a chancre, or especially secondary syphilis lesions. If you do nothing, this will go away usually within 1 to 6 weeks or so. And some of the time, then people will present with multiple syphilitic chancres, usually within the same kind of area, which could be confusing. For some people, might think that it could be herpes simplex, but herpes is usually going to be more of a painful disease. It's not uncommon as this progresses that you get some regional lymphadenopathy, and it's really important to remember that if you test for syphilis early, that test may not be positive because you just don't have enough of a spirochetal load at that point. But if you wait a week or two, retest them, it might be very positive at that point. These are classic cases of chancres. The picture at the top slide that the CDC had, the one at the bottom is one I took when we were doing training center courses in Atlanta. And you see it's that clean base. These were not painful, and these resolve very quickly with adequate management. Labial chancres, you can imagine that if somebody doesn't see it, if it doesn't bleed or hurt or anything, they may not know that they have it in that area. Oral lesions could be confused with a lot of different things. And again, if it doesn't hurt and then it goes away on its own, people forget about it, but the disease is obviously not gone and can go on to cause other complications on down the road. Secondary syphilis lesions usually occur 3 to 6 weeks after the primary chancre appears, and they can persist for a while. They can persist for weeks, and the literature would tell you sometimes up, including a month or two, or sometimes longer. You can see sometimes people with a syphilitic chancre who start to develop secondary syphilis lesions, so there can be some overlap. Seeing cutaneous lesions and sometimes in mucous membrane areas is going to be the most common of these, but the literature would say that the rash is most common, but in a single patient or in some of these populations, it's around 70% of the time. Smaller studies look at it maybe being 100% of the time, but I would suggest that it's not 100% with most of the populations you look at. Lymphadenopathy is not uncommon. And then you see other things like mucus patches, Condylomata, lata, and alopecia, of which I'll show you some pictures of that too. When you're looking at, and as we talk about just in a little bit, doing serologic testing, most of us use an RPR, rapid plasma reagent test, as it's something that's relatively easy to do, but it does take some time. It takes around 15 to 17 minutes for a person to do it. And you're generally limited in running 2 or 3 of these at a time because that's about all you can fit on the card rotator. That takes 10 minutes to actually prepare the card for evaluation. Looking at some of these, the papulosquamous rashes, the guy on the left who saw in Atlanta as well, and it's interesting because he was in a week prior and got treated. So that's kind of the residual of what he had on his feet. The other is from an old CDC slide, just looking at Palmar lesions. So that Palmar plantar thing is something to look at. We had a question pop up one time, do I have to have them take both shoes off or will one do it? I don't know. I mean, it's up to you. I usually have them take both shoes off if possible, and the hands are easy to see. I thought that on this one, the slide at the top, which is from a CDC collection, looked more like a drug reaction. And that's how confusing sometimes these lesions look like. But the history was that that was a secondary syphilis manifestation, responded to penicillin. The bottom is from an old Gower medical slide, which shows you very typically what secondary syphilitic rash can look like. It may not be very robust and look kind of faint. And as time goes along, people notice that if it doesn't itch or bother them, they ignore it and it will go away. This was a patient who came in the Miami STD clinic several years ago who has the flat warts, if you will. Condylomata, lata. Latum is Latin for flat. So these are the flat warts of secondary syphilis and obviously respond very well to penicillin. But when you look at that, it doesn't really look like maybe that's going to be syphilis. It could be, I don't know, maybe so weird looking HPV condyloma lesion, so condyloma acuminata, but then it doesn't. When we had dark field microscopes available, you could easily do a dark field on those and see if you could see spirochetes. But again, that's something that's not quite as available. A really old picture that the CDC used to put in their slide sets, and it shows what they were calling a coin lesion on the face. But I would tell you that if you're just looking for that, which is not that unusual to see these kind of lesions when people have secondary syphilis, as Dr. Ayler and I had noticed when there was an e-consult about a patient, and that's about like what the lesions looked like. They can also look like this and to look more like acne. And that's why sometimes things get misdiagnosed because syphilis can look like almost anything. This was a gentleman who came in Miami to the STD clinic and he was complaining about new onset of hair loss. And he'd been putting minoxidil over the counter on it, wasn't working. And then he was worried that maybe he'd gotten something that was infectious, and so he just came to the STD clinic. Well, I had some other pictures, but there's a little bit more moth-eaten on the other side, but this is really large. And I kept in contact with the practitioners there, and after he got treated, this actually started growing hair back months later. The other thing is to just take a quick look in the mouth if you were doing or in an STD clinic or really focused on, could this be a sexually transmitted infection? Because with this, what you're seeing are these whitish looking lesions a little bit, now it's stuck, there we go, one over here, you're seeing one over and through here, and that really doesn't look like maybe syphilis. It looks more like lichen planus or something else. So again, it's something to think about if you're seeing lesions like that don't really bother individuals. A younger individual who would fit into this, who has sexual activity that puts them at risk for syphilis, etc. I would think about maybe evaluating them to see if maybe they have been exposed to syphilis and this is secondary syphilis. Well, then you go from lesion syphilis into latency. And remember that latent just means hidden. So it's hidden syphilis. They're still seropositive, but they're not expressing lesions. So they're not as infectious at this point to others. But they are at risk for going and progressing on to later stages of syphilis without a diagnosis and treatment. So that's about all you're going to see as a positive serologic test for syphilis, and you can have latency develop even at different stages between primary and secondary stages, that it's quiescent for a while, and then they develop a secondary rash. Between secondary relapses, yes, you can have more than one episode of secondary syphilis, and then, of course, after the secondary stage. Now, what you hear is being described as early latent and late latent. Early latent means that they, let's say in January of this year, They got screened for syphilis and their RPR was negative. And now going into December, they come in and they've got an RPR that's a 1 to 16, and it's confirmed to be positive. So now they've become seropositive in less than a year. That would fall into early latent syphilis. If it's been more than a year or you just can't determine, I got tested in 2017 and haven't been tested for syphilis since then, but now it's really positive. So it sounds like it's been more than a year, or they've never been positive, and the last time they had sex was 4 years ago. And so you're just not sure. That probably is going to fall into latent syphilis, which is greater than a year. WHO had said greater than 2 years, but CDC is using 1 year at this point. We know then that they're at risk for going into late syphilis or tertiary syphilis, and untreated patients will progress to this, some as quick as a year and some it takes many years, as you see here. A lot of this we're not seeing because people would treat all kinds of things with antibiotics, and many of these were going to be forms of penicillin, which they would way overtreat, but probably treat unrecognized syphilis. It's a presumption because we don't have any data of people saying, well, let's look in this population without using antibiotics and see if we see more syphilis. It's a little hard to do. But when you look at these manifestations, I think it's great that we're seeing less late syphilis because you're looking at two different things with this: gummatous lesions and cardiovascular syphilis. I'm not really going to talk too much about cardiovascular syphilis. That one has become pretty uncommon. But it is something for you to keep in mind because we still see maybe once every couple of years or so somebody with what sounds like it could have been cardiovascular syphilis. This is a really old CDC slide looking at the Serpiginous gumma on forearms. There was also a New England Journal of Medicine, CPC, where that they had a person come in with a little bit of neurologic symptoms. They did a CT scan of his head and he had a lesion in his head, which ultimately came down that they did a stereotactic brain biopsy on the person and found out that it was syphilis after having a couple of lumbar punctures looking for other. But it was funny because the only time that they had a CSF VDRL was in the last one where they did the stereotactic brain biopsy, which was positive. But at that point, the CSF VDRL was also positive. And he spent about $250,000 making a diagnosis. You can see these gumma ulcerating as well, and you can see how those would be confusing. The one, the larger one at the top, looks like it could be pyoderma gangrenosum or another disease, maybe associated with inflammatory bowel disease or something else. So it is something to keep in mind. Could this be syphilis? It may certainly not be, but it is something that we see in common presentations of from time to time. Neurosyphilis certainly can occur at any stage of syphilis. It can be asymptomatic, but as time goes along, the chances of it becoming symptomatic increase, especially with immune suppression. And what we have seen over the past few decades has been with the association with HIV disease, especially not well-controlled HIV. Remember, there's early neurosyphilis and late neurosyphilis. So the early one, usually you're looking at acute syphilitic meningitis, meningovascular syphilis, or eye involvement. So those are the early ones, usually within a few months to a couple of years after infection, and late ones are the ones that occur after decades. Those are the ones where we're talking about general paresis, tabies dorsalis, and even with those, sometimes ocular involvement. Meningovascular, the earlier ones, whenever you see, if you would see a younger person with new onset seizures pre-COVID, excuse me, with the clotting that they had, it's one of the things to think about is to get an RPR and see, could this be from undiagnosed syphilis? You see, the other thing would be some aphasia, etc. At the bottom, so now you're getting away from just meningovascular disease, but getting into brain tissue itself with the parenchymatous disease. The term paresis, which is a weakening, actually is a great mnemonic for remembering all the changes that you can see with really late neurosyphilis. And that's changes the P as personality, A as affect, The R is reflexes. And if you think about this, since it's in the brain, it's an upper motor neuron disease, so they get hyperreflexing. Eye changes, you can get optic neuritis, etc., but the most common thing people think about, and as you see it listed lower, is an Argyll-Robertson pupil, which is actually in the song that I was playing you before. It comes up later in the song. And then changes in sensorium, changes in intellect or insight, and speech. The speech is described as really dysarthric, that kind of muddy, thickened speech that people can have. The AR pupils, which you can have with a few other things as well, not just syphilis. Or as we mentioned, optic atrophy is another thing with this. Less common things would be just tremors and face, tongue, hands, legs, something else to think about. So with tabies, now we're looking at getting involvement of just the spinal cord. So tabies dorsalis from the Latin is top of the table. It's the dorsalis is top and tabies is table. So it is those spinothalamic tracts that run down the top of the spinal cord, and that's where you see a lot of these things. I'm not going to go all the way through, but some of the things that could be something to think about if you don't have a good explanation for some of these conditions. The one on the left is just a picture. These are really uncommon, but neuropathic ulcerations where people really lose sensation to their feet. The most common issues that we have with neuropathic ulcerations is going to be having uncontrolled diabetes or long-term diabetes and nerve involvement with that. When I was a fellow, we used to have at the VA Wednesday morning, every other week Wednesday morning ID clinic. And we had a guy that was sent over one time who had some foot ulcerations and said that his feet were kind of numb, and they wanted him evaluated because that these were diabetic foot ulcers and for us to evaluate and treat them. They looked really clean, and when we went through the softback charts, all those things that you used to couldn't find, but all of his glucoses were normal. But he had positive RPR and had never been treated for syphilis. This guy had tabies. Luckily ended up in an ID clinic. The other thing that we used to hear more about was the Charcot joint of the knee being associated also with tabies dorsalis. There's a really nice paper, and I'll be happy to put it on Teams here or send it to through an email. It was earlier on this year, I think it was February, in New England Journal of Medicine, a really nice review of syphilis. So I've captured a couple of those pictures, and this just shows you how convoluted that syphilis can be. And you see that between recurrences with secondary and early latent syphilis and just some of the things we've discussed, and late syphilis or tertiary syphilis and the different manifestations we've kind of talked about. So I think it's a really nice chart when you're educating other individuals about how complicated that this might be. And then we throw HIV into syphilis, which really makes diagnosing and treating, especially follow-up from treatment, more complicated. It usually does require us having more of a frequent monitoring of them if they have become infected, making sure that treatment was effective. But the serology gets a little crazy with some patients with HIV. And there's one manifestation that's been reported more in HIV patients than it had been in 40 years of people without HIV or being immune compromised. And that's what you see on this was Louis maligna. This was a nice report from Open Forum and an ID from 2017. Really nicely done, and included these pictures. One dose of 2.4 million units of benzathine penicillin, and within just a couple of weeks, this had pretty much healed. So again, it's, that looks really uncommon. I mean, it looks like a really nasty foot infection, but it's actually a manifestation of syphilis. So you can go from almost to the ridiculous and sublime from this disease. We do see with HIV seeing more of uveitis and meningitis, and sometimes it's asymptomatic meningitis when you do testing, and maybe they are having some subtle neurologic issues with this, but I think it's something that we get attuned to, and we have been attuned to with our HIV population. Also, you can get neurosyphilis at, again, any stage. So making a diagnosis, if you're trying to do it with early syphilis, we used to be able to do it with dark field microscopy. but that's usually not something we can do. You can do PCR, but that means you have to send it off and wait for it to return. PCR is not currently recommended for blood, although there are different testing mechanisms that people are trying to use. But unless you're getting this when there's a lot, I mean, and this would probably be with secondary syphilis, maybe with that, but there's just not good data at this point. There's no good formal evaluation of serologic test performance with HIV positives compared. There is some data, but we do know that it can be difficult just looking at serology to know how effective your therapy has been. And we'll talk a little bit about that just in a couple other slides. Responses to these tests can be, the higher. We've seen people that have been, their initial RPR was over 5,000 plus. Some have even been more than that. I've talked with colleagues, and it was with an HIV patient. So some really unusual serology. The other thing is people having what looks like clinical syphilis, but the RPR, and it wasn't titered, unfortunately. Some people are still not asking for that, but just getting it, is it positive or not? Remember, there's a prozone phenomenon where you make so much antibody that it overwhelms the test, and you have to dilute it out once or twice in order for the test to become positive. So if somebody looks like they have syphilis and the test comes back negative, make sure that they have done at least dilutions out to 1 to 512, just to make sure there's no prozone phenomenon. And some people got picked up because that they had an increase in their viral load or a decrease in CD4 count where they'd been stable, and was noted in a few reports from early syphilis. Neurosyphilis diagnosis is difficult. It'd be great if there was one checkoff box that says, send NCSF and here's the ultimate test, but it's not. There still remains kind of one of the more difficult diagnoses that we have of trying to use both clinical acumen and looking at this, as well as using serologic testing. And again, we know that CNS invasion can come in early, whether they have HIV or not. There was a nice paper that I didn't put in here, and if we had time, I would briefly show you, but it was the Ross paper, New England Journal of Medicine, where they were looking at neurosyphilis with HIV, and found that actually treatment difference, there's no difference in treating HIV positive, HIV non-infected individuals. Hopkins had also done this study, and they were part of this paper as well, and looking at different conditions, the thing that seemed to be the most effective in diagnosing, or at least suggesting they needed a lumbar puncture, was an RPR greater than 1 to 32, regardless of the stage of syphilis, and a CD4 count less than 350. Unfortunately, when they looked at the number of people that met that criteria, they were LPing about 80% of their patients. So it's not clear what's the best numbers to use. I think it still comes back to, is it really something that you think about? See what their peripheral RPR is, and when in doubt, you can certainly offer a lumbar puncture. I won't go through all this, but it was a really nice MMWR back in 2007 that looked at, unfortunately, people developing early symptomatic neurosyphilis, and they had about 1.7% chance or 1 in 50 chance of developing neurosyphilis if they were HIV positive who got syphilis. Some of these people had persistent symptoms despite therapy, and the most common problems that did give them some degree of disability was vision, hearing, but rarely paralysis. So we do monitor people more with HIV, with treatment, especially if it's early syphilis where you have a lot of spirochetes, if they're a high RPR. And if they've had prior penicillin treatment, sometimes that might have primed them, because this is not an allergic reaction with a Jerks-Wertheimer reaction. It's more of a haptic or a hapten reaction. So you're basically looking at, after that you treat them with penicillin, then that if they can get a rash with this. If they didn't have one, or the rash can get worse, fever, etc. That if they haven't seen penicillin before, that might be an issue. We look for iris as well, and obviously giving antiretroviral therapy decreases a lot of these things. So I won't go on with that. This is the most common thing we look at, is doing a quantitative RPR test, where you are taking this out using serial dilutions to a dilution of 1 to 512, and you're looking for clumping. And this is where sometimes you get into the laboratory phenomenon of, so where's the clumping on this? And is there clumping here? Some people may say yes. Is there clumping here? Yes, obviously. Is there clumping here? Maybe, maybe not. With this one, actually, the 1 to 64 is the actual last one where you see some of this peripheral with clumping. But you can see where there's some variability, and that's why when you're talking about wanting to have a 4-fold or 2 dilution decrease after treatment of syphilis. So if you had a 1 to 64, you would like to see with non-HIV infected individuals to see a 1 to 16 within 6 months. If it's a higher titer, it's probably going to come down a little quicker. If it's a lower titer when you pick it up, it's probably going to take longer for that to decrease. There are 2 other ways of doing it. There's was a really nice CID supplement looking at just serologic testing for syphilis that I can refer you to. What we use in this hospital is what you see on the right-hand side is reverse sequence testing. We've been doing that here since 2004. We're using a treponemal test that's FDA approved for screening. If it's positive, then what we would do is to send that for a quantitative RPR as well as a second confirmatory treponemal test. And the preferred treponemal test is a TPPA. This actually works pretty well. You do see some false positives from the screening treponemal test as opposed to this testing, although you can miss a few. If somebody has an RPR that's negative, but has actually had syphilis many years ago. So there's been not a great head-to-head between these two. CDC would prefer to use this, and this is much easier to use in a smaller laboratory. But if you were a commercial laboratory and you're getting 600 or 700 RPRs to do, you're probably going to elect to use a more automated system like some of these are with an EIA or a CIA chemiluminescent based platform. And this is also from that paper. I'm, because of time, not going to go through this, but when you look through over on the left-hand side, the algorithm used was a traditional or a reverse sequence. I think this is really helpful when you're trying to figure out, and when our primary care colleagues don't know what to make of the results. If it was traditional, you have an RPR that's non-reactive, you're done. If it's reactive, but then your treponemal test comes back non-reactive, it's probably going to be a biologic false positive. Traditional and reverse sequence, if both are reactive, it's untreated syphilis, might be treated syphilis, because this will stay reactive for a long period of time in most people, or it could be a different kind of treponema. It could be Protenue, etc. Reverse sequence testing is what makes people a little crazy when it's non-reactive with an RPR, but reactive with the screening treponemal test, and then non-reactive with the confirmatory treponemal test. Those are the biologic false positives. You're having a non-reactive RPR, reactive treponemal test, and reactive confirmatory treponemal test. Actually, CDC didn't know what to do with this. You're picking up people that may have been exposed to syphilis in the past, have no manifestation. So their recommendation was, if they'd never been treated for syphilis, treat them for latent syphilis. And at least they could say they've been treated for syphilis, because nobody knows really what to do with that. And you see some of the other considerations over here. And if the screening treponemal test is negative, then you're done even with that one. On this slide, the best thing I would tell you is, if you're going to treat someone for syphilis, make sure you get an RPR as close to the time of treatment as you can. We've seen people have an RPR, it's sat for a month or sometimes even 6 weeks. Somebody finally sees it in the medical record and decides to treat them for syphilis. And the RPR they had, maybe let's say it was a 1 to 16, but now they treated them and they follow them up at 6 months and it's a 1 to 32. And he's, oh my God, it got worse. Well, Maybe not, because now, if the RPR was done close to the time of treatment or at the same time that they were treated, it may have been a 1 to 128, and that's a great response. So this can give you some spurious data if you don't do it close to the time of treatment. And we also know low titers decline at a much lower rate than high titers. I don't want to go through all of this. It's also in this nice handout. It goes through a lot of what you probably already know, is that benzathine penicillin, remember, it's really oily. The spirochete is still very susceptible to penicillin, as unbelievable as that is over the decades that we've been treating it with penicillin. If they're anaphylactically reactive to penicillins or other beta-lactams, doxycycline for primary and secondary and non-pregnant women is a great choice for 14 days. If there's a reason that you need to use ceftriaxone, it's 1 to 2 grams a day for 10 to 14 days. Usually if you're using a non-benzathine penicillin, it's going to be for 14 days, the other single dose. And then you see for late latent, for late syphilis, etc. Most of these you know, but it's a nice reference to look through your.
Due to audio difficulties, the audio is not available for the remainder of the session. However, Dr. Toney closed with a slide regarding recommendations for syphilis follow-up. Thanks for joining us today. We will see you next time on ID Podcasts.